the best part is you could treat the patients as skin and color. I'll tell you, I have a lot of patients that come and say, I didn't know I could do anything. People have always told me, don't go to a dermatologist, they're gonna burn your skin. Especially a white Jewish gay guy from the Midwest. That's the best. In New York and the East Coast to West Coast, they're like, what does this white guy know about dark skin? That's what they always say to me. I go, look, I did my residency and fellowship in New York. 70% of my patients were Black, Hispanic, mixed, or Latin, or mixed ethnicity. I was like, I know how to treat dark skin. They're like, you're really white. I don't know. So, but then we show these videos, and they're like, wow, he actually does know. My best friend's Jamaican in LA, so I made him do a peel and did Aerolase treatments for his under eye, and he showed the results, and now all these Jamaican patients come into me, because they're like, we saw that Jamaican guy on there, and it always leads into the people trusting you a lot more when you can do these sensitive issues, treat these sensitive issues. And the risk for those patients are burns, stigma just from going to people because they know even touching their skin, they get pigmentation, etc. The best part is the chromophores that are being attracted here don't even matter so much because of the microsecond technology. That technology allows you to bypass the main components that cause issues, like the melanin in the skin specifically, or the skin itself, which normally would absorb laser and cause a resurfacing. But in this case, we want the energy to go deeper into the follicles or into around in the deeper dermis so that we get that heating that stimulates all these other things below to improve.
We talk about the increase in the skin of color population. And 1 in 4 skin of color patients want aesthetic treatments. But the thing is who is a skin of color patient? So how do you know you have a skin of color patient? So I live in a very, predominantly white Caucasian area of Palm Springs. But there's skin of color patients all around us and in our practices. And what you want to know that person is a skin of color patient and not wait until you do the procedure to find out. So we know that pigmentation is the #1 problem globally. Wherever you go around the world, pigmentation is #1. And it's hyperpigmentation, acne, melasma, PIH, hair removal, and pseudofolliculitis barbae, which is a very big one. And I want to highlight pseudofolliculitis barbae in women. We mostly think about it in men, but it occurs a lot in women. So that is really a passion of mine. And I'm just calling in all women of color to come in because the Aerolase is doing wonderful things. So, here's Carrie Underwood. And this is what I say, beware of the Oklahoma blonde, because she has blonde hair and blue eyes. However, is her skin going to act the way she looks? No, because she is part Native American, and you want to know it before you do it. Multi-ethnic children are everywhere. Here I am with my son. And although phenotypically he may look one way, grow up, get a chemical peel going, and it's gonna be different. Native American with the child. So this is a whole new area. It's so exciting. There are emerging skin types happening right in front of our eyes. And access to care is so important. So why I'm really passionate about this technology is because now the doors have opened with skin of color patients and they have access, where before a lot of people were turned away, no, we don't want to do, and it actually wasn't a bad thing, because better to do no harm than to do a laser treatment and have a complication. But now we have the technology in this 650 microsecond technology to feel safe. So the properties which get us into trouble with skin of color are really 2 areas. Superficially is the melanin in the epidermis, which heretofore has been a real problem. The gold standard, the 1064, long pulse neodymium YAG laser was kind of the gold standard before this. But there were problems with that because it was very technique dependent. And that's why people who didn't really feel comfortable kind of a little bit scared about using this, where now we have a technology which is really kind of operator proof. We'll get into that. But the superficial part, the epidermis, and then last, the exaggerated responses of the fibroblasts, right? Which make an increased risk of scarring. So these are the properties we have to address. So how many people have heard of this skin type classification system? Okay. Oh, great. You're getting better. It's getting out there. So anyway, I published this in 2008. And it's an article in the JDD. And basically, it's a way that we, as practitioners, can classify our patients. Because heretofore, this skin type classification system, the Roberts skin type classification system, the classification systems were always based on ethnicity, gender, where you live, what color your skin is. And really, when you get right down to it, none of that matters. What matters is how your skin is going to respond to insult, injury, and inflammation, right? Inflammation as in PIH. I don't care where you come from, what sex you are, your age, it really is irrelevant. So there are 4 elements of the Roberts skin type classification system. I did not want to reinvent the wheel. The Fitzpatrick system is a very good system. And most importantly, we all know it. We all know what a Fitzpatrick 1 through 6 is. However, historically, these were burning types. So this was all based on photobiology. And that's not the whole picture. It's part of the picture, whether you burn or whether you tan. It's important. However, you can go awry if you just, use the Fitzpatrick. So I introduced a hyperpigmentation scale, which, you can see. Oh, there we go. You can see, and it goes from, I just want to point out, it goes from hypopigmentation, which is H0, to severe and permanent. So we don't think of, and Jason, I'm glad you talked about the hypopigmentation on the cheek. We don't often think of hypopigmentation as a complication, but it often is, and it really traditionally has been much harder to treat. We always say we rather have the hyperpigmentation, can get away the pigment, but when you have that hypopigmentation, it's devastating for a skin of color patient. So you want to avoid that. And how do you know if a patient, I'm going to ask this to everybody, how do you know if a patient hyperpigments or not? Anybody? Got to look, right? You got to ask them and just look. Get them undressed and look for signs of hyperpigmentation. Oh yeah, that curling iron burn, yeah, I got that 3 years ago. Well, guess what? That might be moderate and transient hyperpigmentation, moderate and permanent hyperpigmentation because it lasts for over a year. And the same goes with the scarring. You've got to get people undressed and look and see, do they have scars? And once you do this, you can come up with a code. And again, I talk about these emerging skin types from mixed ethnicity. These people have really unpredictable outcomes. We have no point of reference on how to treat them, a lot of trial and error. And although we have safe devices like the Aerolase, there are still devices out there that are very operator dependent. So once you classify this person, you basically have a skin type code which is unique to them, and they can take wherever they go. You can travel with it, you can communicate with it. When you're referring a patient, you can send them with their skin type classification, and it goes like this. A person might have the following skin type: a Fitzpatrick 4, hyperpigmentation 2, glow-gal 1, right? We don't need to reinvent the wheel with the glow-gal. Photoaging, it's already been done, and Dick Glow-gal did a wonderful job with that. So we have the glow-gal in there. And then scarring 3. So what it translates to is this patient has light brown skin, burns minimally, tans well, with minimal and permanent hyperpigmentation, right? H2. There's no wrinkles with early photoaging, the glow-gal 1, and they have hypertrophic and or raised scars, S3. And that's basically code. Now, millisecond versus microsecond. A microsecond is 1/1,000th, and a millisecond is 1/1000th of a millisecond. So that's very important, and we'll kind of get to that later, but we talk about microsecond technology, and I just want everyone to know, kind of what that is. And the modalities, the limitations, and the pluses heretofore before this laser, when you use topicals, right? Topicals never affected deep pigmentation, and oftentimes our topical, our hydroquinones, had a rebound effect. So it wasn't really a plan. We make a plan for a patient, it can be part of it, but it was never really gonna get you all the way there permanently. And that's the thing with topicals. You could get there, but you couldn't get there permanently because you couldn't use the product permanently. And all the non-hydroquinone agents, we all know, they're good, but you're not gonna get a home run with them, right? So peels, very user dependent. From the way you put it together to how you apply it, it's just all over the board. You have great peelers, you have not so great peeling. So again, not a predictable outcome. Then we talked about the 1064, the long pulse. That was in the millisecond pulse and width domain. Again, gold standard, but lots of issues with hyperpigmentation, hypopigmentation, and scarring, which is user dependent. And then RF is great, but again, a little bit of a different animal. Can be painful. And don't forget, I have treated patients with PIH from radiofrequency. So again, user dependent. Microneedling, great, but again, you're limited to how deep are you gonna go. So there was really a need for a device that could be like a workhorse for skin of color patients. And if you're just starting your practice, you're trying to build a skin of color patient, maybe to distinguish yourself from others in the community, this is a very safe. So for me, there was a lecture that I was listening to that talked about, KOLs and KOLs being paid, and it was a little bit negative. Well, once I learned about this technology, I'm like running down the company to speak for them because I so believe in the technology, and we so have to get skin of color patients into the aesthetic pipeline. I think that, this does it. So we physicians, we're continuing to search for a to-go-to device so we can treat skin of color. Our challenges are, you want to feel as confident with a laser as you do with a can of liquid nitrogen in a white skin patient. Something you can just pick up and use it, and you're going to have a repeatable outcome. You don't want to create a complication. If you're just getting started, you don't want to have a lot of devices. How nice for it to have one device to treat a multitude of conditions. And I want something with proven results. And then again, like I said, I'm fresh out of residency. I don't have a lot of money, but I want to build a diverse practice, or I live in an urban area with diverse populations, and I want to build a skin of color patients and have success.